Hello everyone, welcome to this another episode of iCast on the retinal tug of war. Over the next few minutes, we will be discussing an interesting case of epiretinal membrane giving an appearance of tug of war inside the eye. So multiple causes of epiretinal membrane in children have been described, including trauma, idiopathic, uveitis. But our patient of interest for today is a 17-year-old male who presented with diminution of vision in left eye noticed since 3 years. There was no history of trauma, ocular surgery, redness, or pain. Family history and systemic history were non-contributory. His presenting visual acuity in right eye was 20/20 and left eye was 20/80. So this is the fundus photograph of the left eye demonstrating a clear media, normal disc, a chalky white membrane causing traction in the fovea extending temporally and anteriorly into the vitreous. Multiple ILM folds extending radially from the fovea. Foveal region appears distorted, yellow, and elevated due to traction. Also notice the grayish hue. Red-free fundus photograph clearly outlines the chalky white membrane, giving an appearance of tug of war inside the eye. On subjecting the patient to optical coherence tomography, we can notice heaped up area at the vitreoretinal interface with back shadowing, hyperreflective membrane over the macula suggestive of ERM. All the inner and outer retinal layers up to the ONL are distorted, probably due to traction. Photoreceptor layer, RPE, and choroidal layers appear intact. Based upon these findings, a diagnosis of combined hematoma of the retina and retinal pigment epithelium was made in this patient. So what exactly are these lesions? These are solitary benign tumors which appear slightly elevated with varying degrees of pigmentation and vascular tortuosity. Vitreoretinal interface changes are marked, including traction, fibrosis, and ERM formation. GAS criteria have been used to describe these lesions. These are slightly elevated black or charcoal gray mass involving the pigment epithelium, retina, and overlying vitreous. Hematoma base consists of sheet of hyperpigmented tissue at the level of pigment epithelium. Inner and central portion of the hematoma consists of thickened gray-white retinal and pre-retinal tissue. There is evidence of contraction of the inner surface of the hematoma with displacement of surrounding retina. There is absence of retinal detachment, exudation, hemorrhage, and inflammation. Absence of evidence of any involvement of choroidal. There is absence of evidence of growth on follow-up examination, but based upon the recent literature, growth in these lesions have been reported. The OCT biomarkers include ERM with traction, disorganization of the inner retinal layers, the sawtooth appearance or the mini peak due to the folding of inner retinal layers. When there is full thickness retinal folds, these are called our maxi peak. Convolutions of the outer plexiform layer can give an appearance of omega sign. So how do we manage these patients? The potential cause of visual compromise in these patients include amblyopia, involvement and distortion of the fovea and optic disc. When significant visual impairment is observed secondary to fovea involving traction, surgery can be done. Pars plana vitrectomy with ERM peeling is the surgery of choice. Surgical management, however, remains controversial due to variable visual prognosis. In our patient, PPV plus ERM removal was done with subsequent visual acuity improvement to 20/30. The macula was completely removed of traction. With this, I would again like to draw your attention to the points to retain from this iCast. Causes of pediatric ERM include trauma, uveitis, idiopathic. Combined hematoma of retina and retinal pigment epithelium is also an important differential. These lesions are benign, associated with ERM formation, vascular tortuosity, and variable pigmentation. OCT biomarkers include ERM formation, mini peak, maxi peak, and omega sign. Treat according to the symptoms. PPV plus ERM removal may be considered. With this, I would like to leave you with a thought to ponder upon. What are the systemic associations of chirpy lesions? Thank you for your kind attention. Keep thinking until next time we meet again.